Welcome, and thank you for joining us this afternoon. My name is Kathy Chern, and I am a Consumer Health Librarian at East Brunswick Public Library. This presentation is sponsored by ProPhysio Physical Therapy and the Library's Just for the Health of It initiative to promote community health and wellness. Today's speaker is Dr. Zachary Theinert, DPT ProPhysio Physical Therapy. Before I turn things over to today's speaker, I would like to ask you to please mute your microphone and turn off your video. If you have any questions, please type them into the chat box. And please be aware that this talk is being recorded and will be posted online at the library's YouTube page at ebpl.org/YouTube. And without further ado, I shall turn things over to Dr. Theinert.
Thanks, Kathy. All right, everybody. Welcome to our talk about pain. It's a very exciting topic that I like to speak about a lot. I definitely do a fair amount of education with my patients about pain because it's a problem that a lot of people have, and it's a problem that a lot of people don't quite understand. So hopefully after today's lecture, I'll be able to give you a little bit more clarity on the subject. So I'm going to go into like a screen share mode. I definitely want this to be somewhat of an interactive experience. I know with the screen share, it's not exactly going to be that. So like Kathy said, I encourage you to type any questions you may have into the chat box, and there will be a question and answer portion at the end of the lecture. So hang on to any questions you have, or type them into the chat box, and we'll get to them later. Okay, so just a brief overview of my background here. Go to the next slide. So I have a wide variety of clinical experience with mostly orthopedic and sports medicine conditions. I've been a physical therapist for the last 4 years. I graduated from the University of the Sciences in Philadelphia with my doctorate in physical therapy. I'm the physical therapist and senior lead clinician at ProPhysio's location in Old Bridge. All right, so the big question, pain. What is pain? So a definition here, pain is the result of the brain evaluating information, including danger data from the danger detection system, cognitive data, such as expectations, previous exposure, cultural and social norms and beliefs, and other sensory data, such as what you see, hear, and otherwise sense. So this is a very technical definition, but there are important parts that I want to highlight. Expectations, previous exposure, cultural, social beliefs and norms, and sensory data. So from this definition, it's easy to see how multifaceted pain really is, and it shows how everyone experiences pain differently. Some pain is more intense than others, but ultimately pain is pain. Everyone's perception of their pain is based off of their own life factors. Therefore, each person is so different. I didn't read in that slide that pain comes directly and only from tissue damage. And that's something I'm going to talk about a little bit later. And pain is simply a very, very sophisticated alarm system. This is often the quickest and easiest way for our bodies to communicate to our consciousness that something may be wrong, and I really stress may be wrong. So this is another model of pain, the Bayesian model of pain. I'm going to read this and then we'll talk a little bit more about it as well. So it gives us the probability for certain things to happen when we already know the probabilities of other related things happening. We feel pain because we predict that we are in pain based on an integration of sensory inputs, prior experience, and contextual cues. The experience of symptoms arises out of the inference that the body has deviated from the physiological constants that define health. So a lot there, but this is another very technical definition of pain from a separate source. But again, like a couple of things that it highlights is that the pain we experience is an integration of sensory systems and our prior experiences. Basically, our body is telling us that something has thrown the system off balance and it wants your attention. I mentioned on the last slide with the alarm system analogy that pain can mean that something may be wrong, and rightfully so, right? If we break a bone or we pull a muscle, our body can send a pain signal, and this leads to potentially the biomedical model of pain, which typically equates pain with tissue injury, like a broken bone. This model, however, cannot explain why there may be individuals without any back pain whatsoever, but who have MRI findings of herniated discs and bulging discs and pinched nerves, but like I said, they don't have any pain. So what is the cause of these findings? And if pain is so straightforward with that biomedical model, if it's just that easy, where we can take an image of the back, we can see a disc, we can treat it. Unfortunately, it's not that simple. So this biomedical model cannot explain why there are individuals without any back pain whatsoever. But amputees frequently also experience phantom limb pain, meaning they will feel pain in their ankle even though they've had, say, an above the knee amputation. So the main implication of this model is that what we perceive is only the brain's best attempt at adapting to the world around us, which is constantly being changed by different sensory inputs. So a little bit of a funny slide here, but I thought it was pretty spot on. So acute pain versus chronic pain, right? If you've ever had a paper cut or rolled your ankle, banged your knee on a table, you've experienced some form of acute pain. And typically, these are fairly minor incidents that resolve in a couple minutes, hours, or days. So what is chronic pain, and why do people have chronic pain? Chronic pain is present if that broken bone or sprained ankle has fully healed, but you still feel pain long after healing has occurred. So once we have an injury, our body may become sensitive to the things that we used to do without any issues, such as climbing stairs, getting dressed, mowing the lawn. And that injury has potentially lowered your threshold to activity before that pain comes on. And that forces you to stop whatever you're doing because it hurts. So chronic pain is an altered perception of pain. Works through a principle we call central sensitization, which just means your body and your brain has become sensitive based on your previous experiences, what your body associates pain with. And this ties back into, like I said, these past experiences and what our body predicts something will feel like. So for example, if you always have knee pain when you're climbing stairs, this causes you to associate, your brain just automatically associates pain with stairs. This leads to potentially a fear of stairs because we don't usually seek out pain. Then you start to avoid stairs altogether. This can lead to deconditioning or even dependence on others. So it can have somewhat of a waterfall effect where, take that example I just said, you might now, instead of climbing those stairs to go downstairs to get laundry or to get a case of water from the basement, you may ask a family member to go and do that for you. So you start to modify your behaviors based on what pain is telling you. So you're letting pain kind of control your thoughts and your emotions, and that's something that contributes to chronic disability and chronic illness. So what does this have to do with us, right? Everybody has pain or has had pain at one point in time, and the mindset you take towards managing this pain is essential. Education is the most powerful tool for managing pain. Never stop asking questions to your doctor, therapist, or chiropractor, right? So like I just mentioned, education is the most powerful tool for managing pain. This slide here does not say that exercise, right, is the best tool, or a hot pack is the best tool, or surgery is the best tool. But each of those may play a particular role, but the biggest and most important part is to educate yourself, just like we're doing today, about pain science. Okay, so there are so many factors in pain. Fear, lack of knowledge about what pain even means, the contextual factors or expectations, lifestyle, stress, beliefs, emotions, right? These are all activities that are meaningful to the person. Is there a tissue injury? What are your coping strategies? So my communication as a clinician and you, the patient's expectations, can really alter that patient's perception of their pain and really provide better clinical outcomes. Bottom line, our words matter, especially for myself as a healthcare provider. Words are the most important tool that I use every day. And this is a perfect little quote here. Words are, of course, the most powerful drug used by mankind. And as I started to learn more about pain science education, I've really found this to be fascinating and so true on so many levels. So the bottom line is our words matter. The language that your PT, your chiropractor, or physician uses can ultimately hurt or help you. So if pain is so complex, right, how do we control it? Understanding what pain means is the first step towards having power over it. We know for a fact that those individuals who cope with pain using passive strategies have a poor long-term outcome. So what do I mean by passive? That is, say you feel back pain and you go reach for the hot pack or the ice pack. You take medications, or you ask someone else to give you a massage, or if it's really bad, you might even have to rely on an injection. So passive means that the person that is experiencing these symptoms is not doing anything actively as far as physical activity goes. So on the contrary, those patients who take that active approach when they feel pain typically have a less intense episode of pain, and they recover quicker. So active coping strategies include exercise, which can be stretching or strengthening exercises. And also, I'm going to describe or talk about some of these active management strategies. So active management strategies, and something I love to teach my patients because it helps switch the locus of control when you have pain to, okay, I need to just rest, I need to relax, and it forces your brain to start trying to solve the problem. There are these active management strategies are foam rolling. It's a very easy strategy. You might have even seen these in the gym. Most people have these in their house nowadays. You can go on Amazon and get it for $5, $10 probably. But this foam rolling can be useful to decrease the amount of pain or tissue tension or discomfort that you feel in certain areas of your body. That can help facilitate a reduction in pain and helping you be more active. Some other active management strategies. The picture on the left here, it pretty much dictates or is illustrates some exercises. This woman here is laying on her stomach, kind of bending backwards, standing, bending backwards. This is one means of an active treatment strategy for back pain. This is not appropriate for everybody, but this is what we call the McKenzie method of treating back pain. The picture on the right here is a therapist actually doing a joint mobilization. This is somewhat of a passive strategy, but it's in the active management strategies because through proper education from your chiropractor, your physical therapist, even your physician, they can teach you how to mobilize or stretch a joint on your own. So this is kind of like a hybrid. It can be active, it could also be a passive management strategy. Now getting into passive management strategies, right? This is something that we talked about before. And it's not that I want to say that passive management strategies are so bad that you shouldn't ever do it. You shouldn't ever put a TENS unit on your back, because that is not true. The idea is that you might not always have access to a home TENS unit, or this picture on the right here is actually an EPAT machine. It stands for extracorporeal pulse activation technology. It's pretty long, fancy word, but it's not something that you maybe readily have available. In the physical therapy clinic, these tools can be very powerful when used in combination with, say, manual therapy and appropriately prescribed exercises. This is another passive management strategy, and the picture on the right here is one of our clinicians using what they call the Graston technique. This is a form of soft tissue mobilization or massage, if you will. But this is, like I said, not meant to be the only means of treatment, but it is a way to help facilitate and control and manage pain. Okay, so we're going to get into a couple slides now on a study that I thought was fascinating. And it was a large study, looked at about 1,000 people, and it asked these people that had no medical background what their reactions and feelings towards certain words are that are used by health professionals. The responses to these different words were grouped into three categories. I'll get into a little bit more on the next slide, but they are, the words could mean lead to problematic misunderstandings, not well understood, but have few negative connotations, or three, terms that don't cause alarm. So take a quick second, look at the terms that I have listed here, A, B, C, and D. Which of these words would you think that people found the most problematic? All right, so muscle weakness is the most problematic word that people found. A lot of the participants found that muscle weakness meant that they had an inability to exercise, that this was a permanent injury. The other words, manipulation, prolapse disc, spondylitis, they are more medical jargony, and can just lead to a lot of confusion as well. So even just a word with I'm sure if somebody has been to a physician before, or a physical therapist before, and they've said, "Oh, your back is weak," just that simple statement can program your mind into thinking, "My back can't handle this because I have a weak back." But that is the farthest thing from the truth. So these are some of the other words that I talked about in the previous slide, problematic or lead to misunderstandings. And I want to highlight a couple of these here, right? So pretty words that we use often, even words that I've just used in this presentation, right? Acute and chronic. Other words such as muscle weakness or instability. If anybody has ever been to the doctor and they've told them they have arthritis, right? And that is associated with wear and tear. So these can potentially be negative words that are spoken by clinicians alike, and that really have negative connotations. So this really just highlights the importance of education. So a word that is spoken but not explained can have a negative side effects. Is the word exercise really a bad word? It could be if it's not explained. So we really want to look to the clinician that you are seeing for help, and really look to them for guidance about how to explain these things better. So other things that people thought these terms meant. We already mentioned muscle weakness, an inability to exercise, or that this muscle weakness was permanent. Instability, the back could go out at any time, meaning it's not stable, so it cannot be localized or controlled. Non-specific back pain, the health professional didn't understand the cause of the pain. It is non-existent. Neurological involvement, something is wrong with your brain. You may even die within 6 months. And then, like I mentioned before, wear and tear, the joint is just rotting away. There's no treatment for it, and the doctor thinks it's no big deal. So these words that we think are somewhat second nature to us, and non-threatening, but they may have negative connotations. These words just spoken can be harmful. The clinician must explain these terms and how you can overcome them, or simply debunk some of the myths that surround them. I can't tell you how many times I've had patients tell me they were afraid their back would just break in half. And our bodies are so strong and so resilient. The amount of force it would require to do this would be nothing short of being hit head on by a speeding train. So in the context of exercise, stretching, or household chores, the idea that your back breaking seems pretty far-fetched. And yes, it may feel like that. The pain can feel very intense, but like I mentioned before, pain is just a way for your body to communicate to you. It doesn't know necessarily how to interpret certain stimulus that it feels or that it is exposed to. So it automatically starts to associate pain with everything. And that just brings it to our conscious level of thought, to our brain for central processing, and to determine whether or not this activity is okay. Right? So instead of telling a patient you are weak and that's why there's pain, we have to explain that these muscles could become stronger. And when they become stronger, that can help XYZ happen. And therefore, this is another stepping stone to your recovery and towards remediating the pain. So there are other words we can use as a substitute as well. So another chart here, but the very first one in the top left, words to avoid. Chronic degenerative changes. And a lot of people have heard this if you've ever been diagnosed with arthritis. And chances are, if you live past the age of 65, 75% of you will develop arthritis. So yes, that can be definitely a driver of pain and driver of symptoms, but we shouldn't be describing these as chronic degenerative changes, because that puts the message in the patient's mind that this is not something that they have control of. These are normal age-related changes. Like I mentioned before, instability. That just means we need to build strength. We need to teach you how to build more control. A tear, right? If someone tells you you've torn a ligament, you've pulled it, right? That's a lighter, more comfortable term that everyone's a little bit more happy to hear than you've torn something. Tear, most people associate with, I need to have surgery or this won't get fixed. And just pop down here, disease. And don't think of everything as a disease, maybe more as a condition. That these are more for the clinician to keep in mind. And as we're speaking to our patients, if we're using a lot of these words in the left column, or if you're at your doctor's office and you're hearing these words from your therapist, then that might be putting some negative thoughts into your head. So instead of telling someone that, like I said, they have instability, we can just tell them they need more strength and control. If you've ever heard your doctor tell you you're going to have to live with this forever, you should honestly run, because there are certain instances where that may be true. But still, this does nothing but invoke fear and anxiety towards the ailment, which is obviously counterproductive, especially from a rehab standpoint, when as clinicians, we're trying to empower our patients to take that active role in their recovery, like I mentioned before. So my job as a PT is to help you, not to ingrain fear in you. So telling someone that we can help them develop strategies to reduce and manage their pain, and using words that help you understand your pain, and helping you make the proper adjustments to live pain-free, are all things we can do without using the term, you will have to live with this. So pain does not equal damage. A healthcare professional should empower you, like I mentioned before, the patient, to take control of your recovery. Something that a lot of people do not understand is that pain does not always equal tissue damage. Sometimes it does, but especially in chronic pain patients, this may not be the case. This first study here on pain education showed that a patient's perception of pain was altered after undergoing a series of pain science education sessions. That's exactly what this is here today. This is a pain science education session. So in that study, right, they looked at people that received these pain science education sessions, meaning that there was no exercise done, there was no medication, no surgery, and a large amount of these people saw an improvement in pain. You should be receiving education about your diagnosis, your treatment, and about why you're having pain, because it's so important for your long-term recovery. So that is all of the literature that I need to tell you, right? You do not have to do exercise to control pain. Maybe you just need to learn a little bit more about it. I think exercise is absolutely going to help keep you strong and keep you active, but just learning more about what pain is had a profound effect on symptoms for a large number of people. All right, expectations. So based on what you expect something to feel like, or what you think something will feel like, is going to dictate how your body's going to respond to it. So the stimulus expectancy is the expectation regarding the stimulus or event. The response expectancy is expectation of how your body is going to respond to something. And then that self-efficacy expectancy is the expectation of the self-ability to perform a behavior. So expectations can change the way someone responds to a certain treatment. They can also work together for a stronger effect, or they may counter each other. So for example, if someone has high self-efficacy expectancies when performing an exercise, thinking to themselves, I will be able to do this exercise well, they may have a higher response expectancy, meaning they will feel better after the exercise, or they do not hurt after the exercise. So I can prime your nervous system for success by telling you how beneficial this exercise will be for you because of XYZ. And then you will have a better chance at achieving a successful outcome than if I just said, do this exercise because I said so, or because it's necessary, or whatever. All right, so a little bit of left versus right here. Everything on the left is what we're trying to ingrain in you: hope, optimism, and trust, versus the worrying, pain, and catastrophizing. So we have to foster or encourage optimism, hope, and trust while diminishing worry. We can improve outcomes by discussing things other than pain. If every time, say you were a patient coming into the clinic for physical therapy, and every time you walk in my clinic, I ask you about your pain, what do you think about? You think about pain, right? So what am I conditioning you to judge your progress on in between therapy sessions and over the course of the therapy session? I'm conditioning you to harp on pain and to think about what your pain is doing to you. Think about this. Instead of, what if I ask you, were you able to lift your arm any higher over the weekend? Do you feel any stronger since the last week or over the last month? So this is an easy way I can get my patients to focus on the outcomes and progress in their recovery other than just the pain that they feel. The therapeutic alliance is a sense of collaboration, warmth, and support between physiotherapists and participants. So all the aspects of patient communication that I've discussed so far can all add to an increased perception of the therapeutic alliance. You need to have a sense of trust with your doctor, with your chiropractor, with your physical therapist, and that is really what's going to foster the most beneficial relationship for you. If you've ever gone to a doctor you didn't trust, did you go back again? Or a physical therapist that you didn't trust? If you can't accept the advice that they're giving you, or maybe they don't even give you that much advice, but if you don't feel that they are invested in your recovery just as much as you are, then you're already starting off with a bad head start. Okay, so it's really important to feel like you have a nice relationship with your doctor. They understand you, and they're using this right type of language that they can help facilitate recovery and not harm you or hinder your recovery. A couple studies on the therapeutic alliance. Positive therapeutic alliance is a strong predictor of perceived effect of treatment, change in pain, physical function, patient satisfaction with treatment, and general health status. Therapeutic alliance may be the best predictor of adherence to exercise. Also identifies the features of therapeutic alliance that are important to exercise adherence. Mutual investment, the quality of personal interactions and communication, and an effective bond. Right? So like I just mentioned before, you need to feel that your therapist is invested in your recovery just as much as you are. You have to feel like you matter. And mentally that is part of the process of getting over pain and working through it, and having your therapist educate you on what is normal, what is expected, and that'll help frame your expectations for recovery. If I do a treatment and say I'm doing a joint mobilization like we mentioned before, and I tell you beforehand, this might be a little sore as we do it, it'll likely be sore afterwards and for the rest of the day. But tomorrow when you wake up, you should feel better. Versus just doing the joint mobilization and you come back to my office 2 days later and your shoulder was sore the rest of the day, you're mentally already associating with I went to him to feel better. Like, why is my shoulder hurting now? So if I can prime you by letting you know that this is going to hurt and it's necessary for it to hurt, but it will ultimately help you recover and it will ultimately help you feel better, that can set you up for success down the road. All right, everybody. So wrapping things up here, today's takeaway is everybody experiences pain differently. We've mentioned how your experience really highlights how intense your symptoms may be. We use that stair analogy where if you're climbing stairs and you feel pain, that you start to stop climbing stairs because you don't want to feel pain. So it's really important to just take everything into context and just know that if something hurt because you did it one way, last week, that it doesn't necessarily mean it has to hurt this way. Fear avoidance of activity is the one of the single greatest predictors of having chronic pain. So we don't want people to feel afraid of movement. We don't want people to stop moving, because ultimately that's what life is. That's what our bodies are made to do, is to move. Pay attention to the words your practitioners use. I mentioned this before, like a couple slides ago. If your doctor is telling you that you have permanent back, injuries, and you have not had, 4,000 back surgeries in the last 2 months or 2 years, right? You need to run. These words that these practitioners can use can ultimately frame your mind into thinking you are more disabled than you actually are. Education. Learn as much as you can from your doctor, PT, or chiropractor. After all, they are the professionals. I love it when I get patients that come into my door and they have a ton of questions. I love nothing more than a patient that's engaged, that wants to ask me questions, that wants to learn from me as much as they can. That is my job. Like I said, I am here to help you. So I want to feel like the patient is engaged just as much as I'm engaged in their recovery. And focus on the things you can control, and stay positive. A lot of people have a tendency to dwell on the fact that their back is hurt, or like I said, they rely on passive modalities, heat and ice and destim, and those certainly have a place in the treatment realm, but ultimately hope and optimism is really powerful and can help facilitate your recovery. All right, everybody. I wanted to thank you for attending this Zoom at noon with me. All right. All right, Kathy. I'm just going to try and unmute everybody here.
So if you have any questions, you can also type them into the chat.
So excellent question. Fibromyalgia, most physical therapists have somewhat of a negative connotation with people that are diagnosed with fibromyalgia, because it is somewhat of a diagnosis of exclusion. There is a lot of other testing that might go into the workup, and when nothing comes back positive, sometimes people are diagnosed with fibromyalgia, or it is diagnosed with a clinician placing a finger on a maybe, I think it's 18 pain points throughout the body, and if I think more than half of those are painful, then you're diagnosed with fibromyalgia. What do you feel is the best way to approach PT? Fibromyalgia, light resistance training and aerobic exercise have just been found to be one of the best management strategies that a patient can do for themselves outside of just medication for fibromyalgia. That was published, I want to say, in end of 2019 in the world's clinical practice guidelines. So excellent question there. If anybody has any other questions, I'd love to hear from you. So an anterior listhesis is essentially going back to a term that was used in the lecture. It's a form of that instability, which really means that you need to train your back and your motor control system, your hips, to learn how to control posture and movement strategies, and really a steady diet of strengthening exercises is the best way to support. A mild anterior listhesis may even be considered by most radiologists as normal age-related changes. So with certain changes in the spine, it is definitely possible that you get some sort of translation of one vertebrae on the other, but in no sense does that mean that this is going to be the source of your pain. like I said in the lecture, it's very important to understand what the pain means, right? Like and this is a little bit tough for me to give specific advice to one person that says, you know, they get pain when they do this, like what should they do? It depends on a lot of factors that it kind of takes me to pull it out of you with a lot of questions, maybe during a plan of care with physical therapy. But it's not to say that the pain doesn't exist, but it needs to, we need to figure out what is causing the sensitivity of the system, right? So if you sit, let's say we'll take this as an example. Say you sit in the car, you have a long commute to work, and then you get to work and you sit all day, and then you have a long commute home, and then when you get home, you're tired, and you sit and have dinner, and then you go to sleep, right? So your body is conditioned to sit a lot of the day. So in that instance, doing the opposite to find some balance for your system would be stand more often, to walk around the office every hour, to maybe just even around your desk, just to get out of the position that you have become sensitive to. That is a very simple means of pain control, and not waiting until, so say you're sensitive to sitting. You can sit for 90 minutes before your pain increases in your back. So instead of maybe waiting to 90 minutes for your pain to come on, you get up at 45 minutes, right? So you break it up into shorter intervals of sitting, so your body does not reach that threshold. In the lecture, I mentioned the pain threshold, and you could think of that as like an allotment of tolerance to activity or positions or exercise. And as you go about your day, you're slowly approaching that pain ceiling up here, right? So say sitting is something that is generating irritability, right? So the more you sit throughout the day, the closer you get to this threshold where you're feeling pain up here. But say you go and you take a walk around your building at lunch. Okay, that drops the pain level, that your activity level, back down, right? That threshold. So now you have more of a gap here before you get to the point where you feel pain. So that is where exercise can become useful. It's not that exercise is really preventing pain. Well, it can be a useful tool to just decrease the sensitivity of the system. So it would take more stress to get to the point where you feel that pain threshold. So that is the real utility of exercise in pain management, is you find, and like I said, this would kind of take an evaluation from an experienced clinician to talk with you and to figure out what your habits are, what position are you in a lot, and then figure out which exercises can be useful to you to take you out of that pattern of pain and irritability, and then empower you to each day, you do something that we know can lower that pain threshold. Extremely common to have a period of irritability up to 2 weeks after an epidural injection, really just any injection. The invasive nature of an injection. Most people don't want to look at the needle before they do the injection, but it's usually a pretty decent sized needle, especially if we're talking about spinal injections. There's a lot of muscle that needs to go through before it even gets to the level of the spine. So just that invasive nature of an injection is something that can create sometimes ridiculous symptoms, like people call sciatica, right? Where the pain starts in the back, radiates down the leg. That is inherently very common. Usually most physicians will say after you have an injection, they want to wait 2 weeks and then follow up with you, because they want to see if that injection was effective. And that's generally because there's typically pain associated with it in the short term, but ultimately if that medication is targeted to the right location, that can help alleviate symptoms over time. But yes, it's unfortunate, but it's also something that's very common and very expected. let's go back to the example I used before about sitting in a car for a long commute to work, sitting all day at work, sitting in the car coming home, right? So that involves a posture. I'm gonna have you guys take a look at me here as I'm sitting here. That is going to involve a posture that is sitting like this, right? So inevitably, it's very, very hard to maintain a very upright like posture all day long. So inevitably, if you sit a lot of the day, you're going to slouch and you're going to round your back, and that's okay. That's not necessarily like the be all end all is that you sit a lot, you have a rounded posture, it's going to destroy your back. Couldn't be further from the truth. Say you sit all day in the example I just used, and then when you go to sleep at night, you sit with 6 pillows, or you sleep in a recliner for a portion of the night, and then you go to bed, and then you sit with pillows up. So you're conditioning your body to become sensitive to maybe this position. Like I mentioned before, our bodies are made to move, that we are made to have a certain range of flexibility and what we call normal limits of flexibility and motion. So when you're constraining yourself to those habits that put you in one position for extended periods of time, that's conditioning your body to become sensitive to that position. Am I now advocating for you to go home and lay on your stomach because that's the opposite of sitting? No. I would say a recommended posture, it would really depend more on the person itself and the evaluation or the context with which that sits. So I'm sorry I can't give you a better answer on that one, but the truth is the answer depends. Numbness can be a tricky one. There can be numbness from, a lot of people have heard of carpal tunnel before. The numbness can be related to really anything in the upper extremity, the hand, the wrist, the elbow, the shoulder, the neck. Even your thoracic spine can contribute to numbness in the hand as well too. And unfortunately, there are not many, like all PTs are not alike. I understand you've went to many physical therapists before. It doesn't mean that physical therapy won't help you again in the future, but it's tough to say what could be causing the numbness. Some strategies are ice for decreasing the output of the nervous system, but once again, that is something that we talked about from like a passive treatment standpoint that might not necessarily help with the pain long term, but will give you some temporary relief. So I'm sorry that we can't give you more targeted advice, but the answer there is pretty tough. Okay, but what makes you say that there were no issues in the neck? I guess this can go the other way. So I'll explain. Remember I mentioned in the presentation about how there was imaging, right, of an MRI that you take 100 people, you take an MRI of their spine, and they have disc herniations all over the place, but none of those people have pain, right? The contrary can also be true, where we can take some diagnostic imaging. We can do an MRI or a CT scan, and we can see the radiologist can see absolutely nothing wrong, right? But the pain is still there. So what is the cause, right? That's the key. It is an entire system approach. The nervous system is so complicated. I remember being in PT school and having my neuroscience professor was giving a lecture, and he would point to the slideshow talking about a pathway in the brain about how the body perceives certain things, and then there'd be a big black hole. And I'd raise my hand and say, Professor, what is this area? And he's like, we don't know what happens here. Okay, but we know what the end product is. So that just kind of highlights the complexity of our nervous system, how complex things are. But it doesn't necessarily mean that because there was what they call negative imaging, meaning it appears like there was nothing significant. It doesn't mean that the spine could not generate those symptoms down into the hand. It also doesn't do anything to rule out something from the extremity, from the shoulder, thoracic outlet, or carpal tunnel, or the elbow, or things like that. There's, I could think of 8 diagnoses off the top of my head that can cause numbness into the hand. So that would not even show up on any medical imaging whatsoever. So my response to you would be to continue to try and seek treatment. Continue to try and be active, to get stronger, to get more flexible, even though these management strategies haven't maybe worked in the past. The number one shortcoming I see of patients is that they, once to say I discharge you from therapy, right, and they stop exercising. They think that therapy is just a period in life where they get over the severe injury and then they're better. This is more of a lifestyle change that we're trying to impart on people. And if you're able to more effectively manage your symptoms through lifelong exercise, yeah, you might not necessarily have to do exercise as diligently as you did when you first incurred these symptoms, but you're going to have to continue to keep up with things, months and years after, you've had that initial episode. So my response would be keep searching for answers, keep working to solve the problem, and keep trying to get yourself better, using those active coping strategies. So one of the slides, right? Pain does not equal damage, and a herniated disc is arguably part of aging, just like arthritis is. The truth of the matter is about 50% of all disc herniations reabsorb spontaneously, meaning they have done some studies where they looked at an MRI of someone's back who had a large disc herniation, and this patient has not undergone any treatment, and then these patients were then re-imaged several months later, several years later, and the disc herniations were gone. Meaning that they do not necessarily dictate pain, but they also can just go away on their own too. So no, it's not seen as like a permanent permanent damage or permanent injury. And even if, like I said, even if you have a disc herniation, it could be insignificant. You could take an MRI of my back right now. I probably have several herniations, but have no back pain. So the key with the lecture and what I'm telling you now too is not to dwell on the fact that you have herniations. It's okay. It's something to maybe appreciate that was part of the diagnosis, but focusing on what the diagnosis is and mentally kind of thinking about, I can't do this because I have a herniated disc. That invokes fear into your subconscious, and you're already starting to rule out things that you can do based on the preconceived notion that you have a herniated disc. So don't think of it as you have a herniated disc, I can't do this. You need to think of it and frame it in your mind like, I hurt my back, but I'm strong, I'm resilient, I'm gonna do some exercise, I'm gonna get better. That's the strategy you need to take.
So I think we don't have any more questions, and I think we don't have time for more questions. So I want to thank Dr. Theinert for taking the time to talk to us and to answer our questions. And as I mentioned in the beginning of the program, the talk is being recorded. So the link will be, the link to the recording will be emailed to the registrants, and we'll also upload it to the library's YouTube channel at ebpl.org/YouTube. And I'd also like to welcome everyone to join us for our library's upcoming virtual health programs. Next week, we have a brain health and Alzheimer's prevention on Friday, June 26th at 12 p.m. And next month, we have frequently asked questions about plastic surgery on Tuesday, July 14th at 6 p.m. So you can find out more about these programs and register at ebpl.org/calendar. And thank you all for joining us today. Have a great day. Stay safe.